Welcome to Trying to Conceive with Dr. Sasha Hakman, where we break down the science of fertility, share real patient stories, and explore the latest innovations in reproductive medicine. My name is Dr. Sasha Hakman, and I'm a double board certified OBGYN and reproductive endocrinologist and infertility specialist. I practice at HRC Fertility in Beverly Hills, but this podcast is an independent project created and hosted by me, separate from my clinical work. Don't forget to subscribe so you never miss an episode. And if you want exclusive updates and resources, be sure to sign up for my newsletter. Just click the link in the episode description. We often think about fertility specifically in the context of women's health, but what if sperm can tell us just as much, if not more, about a man's overall health as well as the future of his health? From hormone disruption to chronic diseases like cardiovascular disease, testing men's fertility is a highly underrated biomarker for understanding a man's overall health. And today we're going to unpack all of that with Dr. Justin Houman. Dr. Justin Houman is a recognized urologist specializing in men's health, male fertility, and sexual medicine. He is also an assistant professor of urology at Cedars-Sinai Medical Center here in LA. As a fellowship-trained expert, he's committed to optimizing men's well-being through state-of-the-art evidence-based treatments for erectile dysfunction, testosterone optimization, Peyronie's disease, and reproductive health. His patient-first approach integrates cutting-edge medical advancements with holistic lifestyle strategies, ensuring personalized, comprehensive care tailored to each individual. Dr. Houman completed his medical training at Cedars-Sinai Medical Center in LA before advancing his expertise at UCLA, home to one of the nation's top programs in male reproductive medicine and surgery. There, he mastered microsurgical and minimally invasive techniques for male infertility, hormone management, and complex urologic conditions. A recognized leader in men's research, he frequently lectures and publishes on andrology, sexual medicine, and male reproductive health. All right. So welcome to the podcast. I'm excited to have you here talking about men's health, specifically men's reproductive health, because I think that we just focus so much on women. And even as fertility specialists, on the women's side, I obviously always have the guys get the semen analysis, and we do talk about the man's contribution to making a baby. But I still think that we tend to really focus on the women and what the women can do to improve the reproductive health, while we let a lot of the guys sort of get away with a lot. We just tell them, don't smoke, minimize drinking, and that's sort of it. So I really want to take a deep dive with you about what are some red flags to look for when it comes to reproductive health and how that can impact overall health, the man's contribution to infertility as well as pregnancy loss, because that's a big part of it. But to start with, I just want to go over some basic definitions, because we always talk about male infertility, but for a lot of listeners, maybe they don't even actually understand what that is. People, I think, well, sperm must be bad, but how do we even know that? So I would love for you to just talk about basic definitions. What is male infertility, and what are the most common causes of male infertility that we deal with?
Yeah, so thank you for having me.
Of course.
But so male infertility really is the inability to conceive, and there's no real set definition in terms of how long. Obviously, it takes two to tango, so sometimes it's the male factor, sometimes it's the female factor. But I generally say if you're unable to conceive after about 4 to 6 months, I would consider that some form of male infertility, where it requires some level of evaluation to see what the causes are. Now, when it comes to the causes of infertility, I try to keep it as simple as possible. 4 main causes of male factor infertility. Number 1, abnormal hormone levels. We know that intratesticular testosterone is quite important, not just to the number of sperm, but the quality of the sperm. How they move, how they look, even the quality of the DNA within the sperm, that's very, very important. So there's certain ways in which we can alter the hormones in order to make sure you have good, healthy intratesticular testosterone to have a healthy sperm.
I think a lot of guys don't get that piece of it, that the testosterone really, the concentration of it in the testicles is more important. Does it vary from the serum levels or blood levels?
It does. And then this is the problem where some guys are thinking, all right, if I have low testosterone, I should take exogenous testosterone, like testosterone replacement therapy, which is the exact opposite of what you want to do, because that lowers your intratesticular testosterone. So you want to have like endogenous or natural testosterone production and high levels of it or normal levels of it in order to have good, healthy sperm. So that's a good point. So you really want to have good again to what I was saying, intratesticular testosterone levels. Secondly is anatomical issues. So things like varicoceles, which are like varicose veins of the legs. We get those, men can get those in the testicle themselves. It raises testicular temperatures, therefore it could cause damage to the sperm, damage to the DNA within the sperm. So within that realm of anatomy, there's varicoceles, there's testicular traumas. Anytime sometimes the balloon of or the wrapping around the testicle could have been damaged, which causes problems. There's infections within the testicle. If you're younger, you have orchitis or severe infections that could cause damage. So that's the anatomical piece. The third piece is genetics. I mean, everyone's dealt a hand. Sometimes that hand you're dealt from a gene standpoint, you're unable to produce sperm or you're producing severely low sperm counts. That's a test that we can do in the office to make sure your DNA is not involved. And then lastly, and probably one of the most important ones, is lifestyle. Healthy, to your point about what it means to your overall health, reproductive health, eating healthy, sleeping, exercise, everything that's good for your heart is good for your health or your reproductive health. So healthy living is very, very important for reproductive health.
Would you say that is a really good screening tool if there's abnormal sperm parameters that can create some red flags for possible chronic disease? Because I know a lot of male reproductive urologists are always saying, and you stress on this all the time, if you have done a semen analysis on your patient and it is not good, send them to us because this could be a red flag that there's something else going on. And I've heard of cases like testicular cancer being diagnosed in that process. So what are the things that you are doing in the initial evaluation to look for these things?
So great point. We do know now that there was recently a study that came out that talks about how if you have lower reproductive or lower semen parameters, in terms of longevity, that could be, in terms of your overall health and your longevity, that could be decreased. So it's important. Reproductive health is a marker for your overall health in that sense. So I always tell guys, listen, it's not just about becoming a father. You want to be a healthy father. You want to be a father who can take care of your kids.
I love that. Yeah.
Right. You want to have the energy, the vitality to take care of your kids. So hormonal health is really a big one there. So a lot of guys, even though they're able to become fathers, they have low testosterone count. So we do want to normalize their testosterone, which could obviously help. But things like elevated cholesterol levels, diabetes, high blood pressure, all of these things could really negatively impact your testicular health and your reproductive health as a result of that.
Yeah, I see this all the time where I'll get the abnormal semen analysis and it'll be really abnormal, and then tell them, okay, you need to go see a male reproductive urologist. And they're just sort of like, it's fine, we're just going to do IVF. And I think that a lot of guys get sometimes, I don't know if it's lazy or intimidated. I don't know what causes the hesitation of sometimes wanting to take that referral and actually go see the urologist, someone like you, to help really make them feel better. And maybe that's the piece that we're lacking as fertility doctors, saying, hey, your sperm doesn't look great. You're probably not feeling great. Please go see a male reproductive urologist because you're also just going to be better.
Yeah, it's an interesting thing because I think there's like a taboo. Guys first of all, they don't want to know that they have low sperm counts. It's a topic they don't want to discuss. They don't want to deal with the evaluation process either because it requires, again, you're getting examined from a physical, the physical exam. Some guys don't like that idea. There's a number of taboos associated with it in terms of having a guy engage in that conversation. But the earlier you do it, the better. I can't stress that enough.
Totally.
Yeah, discussing that earlier on, you will be better off as a result of it.
Yeah, and you also mentioned the testosterone thing because that's a really big deal where guys come in, they're already on testosterone. They don't even realize that this is an incredibly effective form of birth control. And oftentimes there will be men who are on testosterone also taking Clomid to try to prevent azoospermia or no sperm being present in the semen sample so that they're still continuing to make sperm, but it seems to be very suboptimal. how do you really try to convince these guys to stop their testosterone?
So this is a very common question, a common reason why patients come in. So a lot of young guys, especially these days, they're more proactive about their health, their hormonal health as a result of it. If they're experiencing low testosterone, they'll go to one of these testosterone clinics. They'll put them on testosterone replacement therapy in their 20s, 30s without telling them about the fertility consequences. So a lot of times a young guy, otherwise healthy, will come in. You look at him, like, you look good, everything's healthy, but you have 0 sperm. And when you ask them, are you on testosterone? They're like, yeah, I've been on it for 5 years, for example. And when you take testosterone, supplementation, you're decreasing your sperm counts, really shutting it down. To your point about it being a great form of contraception. Some guys, what they do during that time is they'll stay on Clomid, which preserves some testicular function, gives the testicles some activity. So when they come off the testosterone, the time until the point where they could produce sperm again is a lot shorter. So what would typically be about 6 months, maybe we could get it down to 2 to 3 months. So in those scenarios, Clomid can help. It definitely doesn't hurt, but it can help. But ultimately, the tough part for us is when a guy is on testosterone replacement therapy and he comes off of it, we have to shut down once the guy comes off testosterone replacement therapy, we have to ramp up the natural testosterone production in the testicle, and no guy feels as good as they did when they were on testosterone replacement therapy. So inevitably,
even if it comes back to a normal level?
Well, during that period where they're going from when they're going from
that
testosterone
drop.
replacement, that drop, and invariably they always come in. They're like, I just don't feel good. I'm like, what? Can I be on testosterone? I'm like, look, if you want to be on testosterone, we're back to square one.
Yeah.
So I try to do everything I can to ramp it up. And for some guys, it's easier than others. But these guys who are on high doses of testosterone replacement therapy, it takes some custom-tailored hormonal approaches to make them.
How long does it take on average to get the sperm back, or at least get their intratesticular testosterone levels back?
I would say, like, anecdotally, at least in my patients, anywhere from like roughly 3 to 4 months. Sometimes as early as 2 to 3, but generally speaking, about 3 to 4 months.
It's not bad.
Yeah.
Do you ever see cases where it just takes forever and 4 months later you're still not in a great place, or is that pretty rare?
Older guys who have been on testosterone for like a decade, maybe it takes a little bit longer, but generally speaking, we're able to find some sign or some hint of natural sperm production. And if a guy at some point is like, you know what, I'm sick of this, I'll do IVF. So we'll go, even though if he has low sperm counts, we'll go there, we'll do a TESE, we'll do a testicular sperm extraction, use that sperm for IVF.
But I feel like IVF outcomes are never quite as great then, right?
Yeah.
Yeah.
But listen,
so, you're weighing, the success of an IVF cycle, and having to go through another testicular sperm extraction sounds kind of miserable.
But every patient, you just want to lay out the options for them.
Totally.
And have them make the decision, whatever's best for them.
Is it commonly done where some guys are like, just extract the sperm, I want to stay on the T,
No,
I feel great? Okay.
No. I think probably in my career twice.
Okay. Yeah, that's not bad at all then.
Yeah.
So, it's funny because a lot of the men in my life, including my husband, they hear from all their friends about how great it feels to be on testosterone, and that when they work out, their muscle recovery is phenomenal, that they are able to build muscle easier. I feel like there's this aesthetic part of it too, as well as just this overall feeling energized, and especially when we're dealing with lifestyles that are busy, usually associated with chronic fatigue. And so what that has led to with these guys that I know, and even with my husband, who's like, well, we have 2 kids and we have embryos on ice. Why can't I just start the testosterone? And I always really kind of shut him down. And I say, until we're done having babies and it's official, I don't even want to hear about it. But would you ever be concerned about, first of all, what range of testosterone, when you're getting it drawn, makes you think, okay, it makes sense for you to supplement some testosterone, if ever? And I'm talking like normal, like what part of a normal range would make you think that it's even beneficial? And then would there be concern that, let's just say there's some negative side effect from being on the testosterone for so long that now they have to discontinue it and they're stuck feeling like crap because they have no testosterone, and you're hoping to sort of restart that testosterone production naturally?
Yeah. So I'll answer the first part. In terms of the range, we say, our guidelines and the governing bodies really tell you it's 300 to 1,000. And that's very unfair, at least the way I see it, because what I need, my range of normal testosterone is very different than your husband, and it's different than, let's say, a football player, right? Everyone's ranges are different. So you don't want to necessarily treat the number, you want to treat the symptom. So if a guy comes to me, he's experiencing low testosterone symptoms, and depending what his age is, we can make adjustments, or we can make, so if a young guy who's still interested in fertility, Clomid or enclomiphene is a wonderful option where, maybe they're in the 300 range, 400 range, but they want to be a little bit higher. We could naturally get them a little bit higher and safely do it. It's safe. These Clomids and clomiphenes are HCG, all very, very safe to optimize your hormones to get you into that range where you could feel good. So that's for the younger guys. Older guy comes in who's past the age of fertility, and he's interested in being on testosterone replacement therapy. That's a great option for them as well. And again, we always want to do it in a safe fashion. But ultimately, I guess I could summarize it by saying you want to treat the symptom, not the number.
Yeah, that makes sense. I never really thought of it that way.
Yeah.
Yeah, because I have seen guys come back at 300 and, it feels low. I mean, I know that that's technically part of the normal range, but you're on the very bottom of that range, which is a massive range.
Massive.
So, yeah, it doesn't appear that would feel good, especially as you get older.
Yeah, and look, I'm a huge believer in testosterone. Honestly, I can't wait till the day I'm on testosterone in many ways. I mean that, but it's incredibly safe. I mean, if done right. We published a study last year looking at the cardiovascular risks, none. Prostate cancer risks. It doesn't cause prostate cancer. It may unearth it, but it doesn't necessarily cause prostate cancer.
Okay.
It's protective. I mean, they've done longitudinal studies. Testosterone
That's really
replacement
good to
therapy,
know.
when it's done correctly, it is incredibly safe, and in many ways, actually, it's protective, and you could probably live depending on what data you look at, you could live longer as a result of having normal testosterone levels versus having low testosterone.
Wow. Yeah, I guess that would be sort of parallel to hormone replacement therapy for menopausal women. If you start early, then it's protective. And the Women's Health Initiative got such a bad rep for hormone replacement and caused this massive fear for patients and doctors alike. Doctors not even wanting to prescribe estrogen for menopausal women with horrible hot flashes because of the fear of cardiovascular disease, heart attacks, strokes, colon cancer, etc. And so it sort of led to this huge trend of no longer prescribing the meds. But then when you do a secondary analysis on this data, which, by the way, that study is just so poorly done for a number of reasons, but when you really do a post hoc analysis or a secondary analysis of the data that was published, you realize that actually, if you start it really early on and you don't wait 10 years after menopause to start these meds, it could actually help with longevity, quality of life, just so many benefits to being on it. But if you Google estrogen replacement in menopause, it's going to tell you all sorts of scary things. It's going to make you think you're going to get breast cancer from it, or that you have a much higher chance of getting it, when in reality, it's the combination of estrogen and progesterone that just provides a very marginal relative risk of breast cancer that's really just not all that significant. It appears it's kind of similar.
Essentially the same. Exactly.
Okay. Wow.
Huge taboo against testosterone from the first study, but since then we've disproven everything. But unfortunately, the first message was the one that screwed it up for everybody.
So same idea, study for on the men's side showing that, very risky, don't do it.
Right, prostate cancer. But literally, I think they've done 20, 25 studies since then, and all of them have disproven that original study.
Wow.
Yeah.
Wow, I didn't even know that. That's crazy.
Yeah, it's great. Testosterone replacement therapy, when done appropriately, it's incredibly safe.
So basically do it under the care of someone like you.
Yeah, myself, a urologist, an endocrinologist, absolutely. It's very, very safe.
Wow. Okay, that's amazing.
Yeah.
So as we sort of get back to male fertility specifically, I know you mentioned when you do a physical exam, you're looking for other things like, other causes of infertility aside from hormonal, which that's easy. You just get a blood draw. But in your case, with your specialty, you're doing a physical exam, looking at the testes, looking at the scrotum, possible varicoceles. Mm-hmm. So my question about varicoceles, would you say that most men are not in tune to the possibility of having varicoceles?
Very much so. Very much so.
Interesting.
So we know about 15% of men have varicoceles.
That's a lot.
It's a lot. And sometimes it's the culprit for infertility. So varicoceles cause 3 problems. Number 1, testicular pain. Number 2, infertility. And number 3, which a lot of people don't know, is low testosterone. Right? So those are the 3 reasons why varicoceles should be addressed. So if a young guy comes in, he has low testosterone, I'll check and see if he has a varicocele, because if we could always put him on medications to boost his testosterone, or we could fix his varicocele, and by fixing his varicocele, provide long-term, like we fix the cause of his of his low testosterone. So those are the 3 reasons. Like I said, 15% of the time they have it, and 40% of the time it's the cause of male factor infertility. So it's one of the main reasons why men are experiencing infertility, and probably the most common surgery that I do, at least for male factor infertility.
If you're trying to conceive, the supplements you take now really matter, especially when it comes to supporting your fertility from the inside out. As a double board certified OBGYN and reproductive specialist, I'm often asked what I personally recommend to patients preparing for pregnancy. My go-to is Bird & Bee's Female Fertility Power Prenatal plus CoQ10 pack. It's a preconception powerhouse, combining your prenatal, DHA, and powerful antioxidants into one easy daily pack. So no more juggling bottles. Here's what sets it apart is the clinical grade support for egg quality. You get 600 milligrams of CoQ10, shown in studies to significantly improve IVF outcomes and boost ovulation for those with PCOS. It also includes NAC, which helps reduce oxidative stress. And unlike most prenatals, it doesn't skip essentials like folic acid, the only form still recommended by the American Society of Reproductive Medicine, methylated folate, choline, preformed vitamin A, nutrients that play critical roles in fetal development and egg health. Plus, you're getting iron to improve blood count and vitamin E for improved blood flow. It's vegan, gluten-free, third-party tested, plus tested for heavy metals. It's also formulated by fertility doctors and naturopaths, so I know my patients are getting the support they need with none of the unnecessary fillers. Want to try Female Fertility Power Prenatal for yourself? Head to birdandbee.com/Sasha Hakman MD and use the code TTC Podcast at checkout to get 10% off your first order. That's TTC Podcast for 10% off, because your fertility deserves clinically backed support.
To fix the varicocele.
And you said one of the symptoms is pain.
Yeah.
So is there ever a scenario where it's painless?
Yes, there definitely is. It depends on how it happened. But if I could backtrack here, what a varicocele is, it's basically, like I said, varicose veins of the legs. So blood pools around the testicle, and the typical pain associated with that is it's like a dull, achy pain. Gets worse throughout the day as gravity keeps pulling blood towards the testicle. Yeah, it creates that heaviness. And guys will say when they lay down, or they wake up in the morning, the pain's gone, or it's much less than it is at the end of the day. That's the typical pain associated with it. But again, not everyone is experiencing painful symptoms as a result of the varicocele. They could have a severe grade 3 varicocele and not even know it.
Wow.
Yeah.
And would have come to you sort of just as a referral, for example, not necessarily coming to you for pain.
Yeah, exactly. I had a guy a couple weeks ago or last week. He came in because he was having, he noticed blood. He noticed blood in his semen. Not that the varicocele was associated with that, but he had no idea. So I did an exam. Like, well, you have a grade 3 varicocele. And he's like, I'm trying to have a kid. I've been trying for the last 3 months, not knowing that he had varicocele again. So now we'll get a semen analysis. We'll make sure. So a lot of guys don't even know that they have it. But if you're a male experiencing fertility, check to see if you have a varicocele.
Yes.
Yeah, a very easy thing to do.
Very easy thing to do. How's the surgery like for it? Recovery-wise, I guess you can also talk about the process, because not everyone knows what that's like.
Yeah, I actually have to go do one after this. But it's a small incision. The way I do it, I do a microsurgical subinguinal. So basically get as close to the testicle as possible. Small incision, about 2 to 3 centimeter incision. Using a microscope, we tie off the veins. So the spermatic cord has an artery, a vein, and a tube, the vas deferens, which carries the sperm. But anyways, we just go in there, we isolate the veins, tie off the veins, and as a result, and by doing so, we're able to prevent that blood pooling around the testicle. And the body always finds collaterals or other ways of getting the blood back to the heart. So, and it's straightforward. It takes, I don't know, maybe an hour, outpatient. You're able to get back to your normal routine within a week.
Wow. Amazing.
Yeah.
Not too bad.
Not too bad at all.
Wow.
Not too bad at all.
And I know, and I've actually even seen this on Instagram because I follow a lot of infertility accounts of women and couples who are in the process of trying and they're documenting their IVF journey. And there's one really sort of famous couple that has a really, really large following after showing her very brutal journey to finally a pregnancy now, I think 11 years later. And in the process of their fertility evaluation, her husband was sent to a urologist who diagnosed him with testicular cancer. And I've heard of a handful of these cases where it sort of, as an REI, I think, man, I need to send all my guys to you so that if there is ever a scenario where you can unmask or discover something like this, what are the red flags where it sort of adds that to your differential where you start to think, well, maybe there is a cancer diagnosis here?
The cancer diagnoses are hard for testicular cancer. I mean, the best thing I would tell you and to tell patients really is have the guys do self-exams, testicular self-exams once a month in the shower. If they feel anything,
oh wow,
yeah, if they feel anything abnormal on, if they feel something funny on one testicle, try to find it or see if it's on the other testicle. If not, then definitely see somebody. But there's no real symptoms associated with testicular cancer, really. It's in rare cases you have pain. In rare cases you have this, this
mass
heaviness
or something.
But you have to. The best way is really to do an exam, and guys should be doing this. Guys in their 20s and 30s should be doing this every month. At home by themselves.
I did not even know this.
Yeah, absolutely. That's the peak. 25 to 35 is the peak for testicular cancer for men. Yeah,
because as women, we're always, taught, and I always preach to my patients, self-breast exam, you can find something and we can catch it early. But I didn't know that about men.
Yeah.
Wow.
Doing it in men is very important. It's easy to do.
Do you think most men know this?
No.
That's scary.
Yeah, they really don't.
That's so crazy. I feel like all primary care physicians should be made aware, to tell their male patients, hey, self-exam all the time.
But as you know, primary care doctors are so inundated with other stuff.
Totally.
Yeah. And young guys aren't going to their primary cares.
Yeah. I guess that's true.
A 25-year-old guy, he's not going in for his annual physical.
Yeah.
Very rarely is he.
I don't even have a primary care physician.
Neither do I.
I'm a doctor.
I'm my own doctor.
Yeah, exactly. I doctor myself, which isn't great.
It's very bad.
Yeah, probably more likely to do too much or too little when you doctor yourself.
Yeah.
But yeah, oh my gosh, that's funny. Okay, so I follow a lot of wellness accounts too on Instagram, and the biggest thing that people are talking about when it comes to men's health and men's fertility is the massive decline in sperm quality over the years. And there's this sort of viral post about how sperm has declined by 50% in the last 50 years. What do you know about this overall trend in decline? What is causing it? What do we know to be causing it? And what does the literature really say about it?
It's very big on social media, and it's somewhat controversial. I don't know how true that 50% decline really is, because to me there's a couple of things contributing to it. Number one, we're screening more for we're doing more semen analyses than ever before. So as a result of that, we're capturing more data. So if a guy who has low sperm counts and let's say 50 years ago was able to conceive no problem, now we're able to capture that he's having low sperm counts earlier on, if that makes sense. Mm-hmm. So there's at-home testing. Younger generation of men, as I mentioned, they're more proactive, so they're testing more, and as a result of that, we're capturing more data. But I will say, the ways we live these days, more so than 50 years ago, is we're much more sedentary. So we're not moving around as much. Our vitamin D levels are lower. As a result of that, our hormone levels can be negatively impacted. We're not exercising as much. We're sitting down most of the day in desk jobs. Then when you come home and you're driving in your car, On your way home, then you sit down, you watch Netflix for the night, whatever it is. But all of that over time, that just sitting down most of the day, you're increasing testicular temperatures, not drastically, but just enough.
Oh, interesting.
Over the course of years, and that can negatively impact it too. So I think it's a combination of both the current lifestyle that we're in, as well as just more screening, or we're doing more semen analyses than ever before. However, having said all this, maybe sperm counts have declined, but are we having an issue with fertility, male factor infertility with more difficulty? I don't necessarily know the answer to that, because we're also, at least here in LA, men are having kids at a much, much later age.
Yeah.
Or much later age, I should say. So invariably, those guys are going to struggle with fertility now or 50 years ago. It doesn't matter. So
True.
So how much of this is actually clinically impacting fertility rates? I don't know the answer to that. And my gut is not that much.
Interesting. Yeah. I mean, I guess there's a lot of confounding variables there.
Because female fertility I think that's a bigger issue, if I'm mistaken.
Well, it's hard to say, because we know that infertility is on the rise. So it used to be quoted 1 in 10 couples. Now the CDC says 1 in 6. And so we have more data showing that there is a higher rate of infertility. We know that in 40 to 50% of infertility cases, there is a male contribution to that infertility. And so in my mind, that statistically should mean that male infertility as well as female infertility is on the rise. But like you said, there's a lot of variables. We're waiting longer to have kids, and that definitely makes it more difficult. And particularly female age, it's extremely sensitive to the egg quality and egg quantity decline. But then now, I think there's more awareness for fertility preservation. I think there's a huge lack of awareness for men and the effects of age on reproductive health for men, that it does decline as men get older. And there probably should be a lot more awareness for fertility preservation for guys, which is so much easier, so much cheaper, a lot less involved.
Oh, yeah.
All you have to do is ejaculate in a cup, and we freeze that. And your biggest expense is the storage fee. I mean, it's really not that financially inaccessible for the majority of people. But, that kind of makes me want to segue to what we do for women. Is we always preach about, in terms of your well-woman checkup, it wouldn't be a bad idea to serially check your AMH level, anti-Müllerian hormone, which is a marker of ovarian reserve. And although that does not correlate to the likelihood of pregnancy, what it does help for some women is if they are sort of on the fence about egg freezing, they don't necessarily know that they want to pursue any sort of fertility preservation, but they do want to track their ovarian reserve to see, is there a rapid decline? Can they catch something that is in the process of happening? Would you say that for men, it would be prudent to randomly and serially check a semen analysis, even if not trying to conceive?
Yeah, it's a really good question. Someone asked me this over the weekend as well, if it makes sense for him to do something like that. I'll say this before I answer the question. It's a tough question to answer, only because the semen analysis is not it's not a perfect test by any means. It's a quick snapshot of your fertility at that moment. Can the semen analysis vary from month to month, quarter to quarter, every 3 months? Absolutely. So the question is, like, how much time and effort and mental anguish and over-treatment are we going to engage in as a result of one bad semen analysis? And I don't know, but my sense is we'll probably over-treat a lot of guys when we probably don't necessarily have to. But if I had to make a recommendation, I would say, if a guy's in his 30s, even if he's in mid-30s and he's single, banking your sperm or saving your sperm is probably a good idea, because, to your point, it's first of all super easy. There's at-home testing companies that do this now, and it's so cheap. I think
But they'll freeze it for you?
They'll freeze it for you, yeah. It's like $200 a year. You literally do it in a cup at home. They have a preservative in it that's, proven that it does a good job in terms of preserving the quality of the sperm. You send it into their cryobank and they freeze it. And again, it's no more than $200-300 a year. And I think the cost of that is actually going down yearly. So it's a no-brainer. It's
super accessible then.
Yeah, super accessible. So if you're a guy in your 30s, and there's no harm in doing it, right? Because
totally.
Worst case scenario, you just use that sperm.
How many samples would you recommend freezing?
If you go to a cryobank, they require a few ejaculations, but you have to remember, like a guy, when he's ejaculating his sperm, there's tens of millions of sperm, sometimes hundreds of million, and all you need is one per egg.
Yeah.
So if you have normal semen analysis, a single one ejaculation, maybe two, is more than enough.
So as reproductive endocrinologists, oftentimes what we actually talk about is our testing for sperm is so limited, where we're looking at the concentration, we're looking at the motility, we're looking at the morphology, and the morphology is also very subjective.
Very subjective.
It's basically relying on an andrologist to look under the microscope and deem that head to be too small or too big, but somebody else might not. And so now the percentage of normal morphology is drastically different, because in a sample of possibly tens to hundreds of millions of sperm, we're looking at maybe 100 sperm and how they look, because you can't look at the entire sample. That's impossible. But what do you say to someone who says, well, this information is limited? Even though the sperm parameters are excellent, there could still be a male contribution to infertility. Would you say that that is false information, or would you say there is a possibility there?
Possibility of
there being a male contribution to infertility, even though the semen analysis is pristine? Yes,
definitely. And the next test for that is the DNA fragmentation, where we're looking at because think of the semen analysis like a bird's eye view of it, and then the DNA fragmentation looks at the sperm itself, the quality of the sperm, if you will. So we could see that. We could see a guy who has a varicocele, let's say a mild varicocele, and he has great semen parameters. He tries to conceive, they have a miscarriage, or one miscarriage, two miscarriages. We do a DNA fragmentation, like, well, look, there's an issue here. The DNA is damaged, and then we'll examine him, and he has a varicocele. So to answer your question, yes. A semen parameter is not always a perfect test. It's a good test, but it's not a perfect test.
What percentage do you think that sperm contributes to chromosomal abnormalities of embryos or miscarriage? Because I think that prior to doing DNA fragmentation testing, it was always like, okay, the egg contributes 99% of chromosomal abnormalities in the embryo, which I think is like a really unfair assessment for us to say that the egg is contributing to 99% of abnormalities. That's kind of crazy. I don't know if we even know that answer. Do we?
I don't think we do. I don't know the number, but like anecdotally, I could say maybe 20 to 30% of the time.
Yeah, I've seen some reports about, 30% being quoted, but yeah.
I would say it's not like half and half.
Yeah.
But yeah, I'd say about maybe like a quarter of the time it's the male factor.
Which is a lot.
Which is a lot. But again, because it's, men just aren't engaging in these discussions.
Yes. They're not.
Because in fairness, each time, like you're ejaculating tons of sperm, you just need one, right? You need one of those.
But would you say that it's important for all the guys to get DFI, which is the DNA fragmentation index? Would you say everyone should do that with their semen analysis right off the bat?
Maybe not.
Or not so much?
Not so much. But if you're struggling, depending what your age is, but the earlier you assess it, and I hate to keep coming back to this, but the earlier you assess it, the better. Because whatever we do, at least from my end, whether it's a hormonal change, whether I recommend a lifestyle change, a surgery, it's going to take you a good 3 to 4 months at least to notice the benefits on the semen analysis side. And then from that point going forward, who knows how long it's going to take to conceive. So it does take time. It's not a lot of time, but the longer you wait, the more frustration. And because it takes two to tango, there's a number of variables involved in this.
Yeah, I know that now we finally have testing available when it comes to pre-implantation genetic testing of the embryos, or PGT. We would always just test to see which ones are chromosomally normal or abnormal. And if it's abnormal, we assume it's the egg. Once again, always coming back to assuming it's on the female side. But now there's the ability to do PGT plus with some companies where they'll check to see if it's a paternal contribution.
Oh, nice.
Which is really it's really neat to see. I don't think enough people are utilizing this tool yet because, unfortunately, it's added cost, which makes it more prohibitive for a lot of patients to end up doing. Probably useful for recurrent pregnancy loss patients because I think that we always, once again, really just assume that it's the egg and not the sperm if the semen analysis is normal. But I do love that your societies have come out and said, if you're dealing with recurrent miscarriages, check the DNA fragmentation.
Oh, yeah.
And I know that urologists really are big advocates of that, even though on the women's health side, there tends to be a lot of discouragement of doing it because, there's no standardized lab and there's a lot of controversy in which test to do is better. And I think that as reproductive endocrinologists, for the most part, our knowledge of the different types of DNA fragmentation testing is a little bit limited. Do you know about the different types of testing out there? Does it really matter which lab you're utilizing?
I would say, so there's obviously differences, but I would say just go for convenience. Truly go for convenience.
Okay.
There's the at-home testing companies. There's a couple of them that do this and use that because obviously whatever's easier. But if you want to do an at-home test, it's completely fine. There's tests where you could go to a embryology lab and they could do it for you.
Yeah, we do. We offer that too. Yeah,
exactly. So you could go there and do it, but go for whatever's most convenient. Because generally speaking, we're going to get a good idea.
So even the at-home stuff can look at DNA fragmentation?
Yeah, well, like ReproSource, for example, is a company that does that, and they do a great job with it.
Wow.
That gives you a lot of good data on it. Yeah,
that's great,
yeah.
Especially for the guys who are really nervous and don't want to go to a clinic.
Exactly.
So they have the ability to do it in the privacy of their own home. So it's better to do it that way than not at all if you don't want to see a doctor about it.
Exactly. Or you don't want to be in that environment giving a sample.
Yeah.
Which I get. It's weird.
Yeah. Amazing. Well, this was such a good conversation. I learned so much. I'm sure a lot of the people listening are going to learn so much. Just to sort of wrap it up, what other big lifestyle tips would you give to guys who are trying to naturally improve their testosterone levels and possibly consequently improve their sperm parameters?
Yeah, so what's good for your heart is good for your health. What's good for your heart is good for your, the same thing, it's good for your reproductive health. So eat right, and obviously there's a wide range of things, but just try to stay away from processed foods as much as possible.
Right.
Good healthy proteins, complex carbs, healthy fats, sleep, at least 7 hours of sleep. That's good for your hormonal health. Exercise, combination of heavy weightlifting and cardio 3 to 4 times a week. The hardest one I would say is stress. Minimize your stress as much as possible because that could lower your testosterone. And then the one thing I've been preaching for the last couple of years is, and it's kind of this trend of the contrast therapy, which is quite popular here in terms of saunas and cold plunge.
Yes.
The back and forth. The sauna is like increasing testicular temperature could really negatively impact your sperm health, especially if you do it for long periods of time, quite frequently. Cold plunges are okay. There's no problem with the cold, but the heat is a problem.
Interesting. Yeah. So the cold is fine, but the heat is a problem.
And put your cell phone in the back pocket as much as possible. Okay.
Those are really easy pointers.
Yeah.
So anytime you're getting close to wanting to start trying, no longer go in the sauna.
Yeah. If you're going to do the sauna, if you're desperate to do it, just put an ice pack down there.
Okay.
Yeah.
If trying to conceive, but if you're not trying, then it doesn't really matter.
It doesn't really matter.
Okay.
Yeah.
And final thing, we can't talk about male health and the health of male or the health of sperm without talking about supplementation. Mm-hmm. People are always asking what supplements help improve sperm quality. What are specific recommendations you make to your patients for supplements?
We do know like vitamin E, coenzyme Q10, those are tried and true in many ways. Historically, those have done a fantastic job. There's more and more research going into the supplements. As probably a lot of it has to do with the environment that we live in. There's more environmental toxins, and with that comes DNA damage or DNA oxidative stress. So a lot of antioxidants are helping too. A lot of these newer fertility companies or fertility supplement companies, they're introducing a lot of antioxidants into their at least their male fertility supplements, and those are helping as well. They move the needle. They definitely move the needle for men. Some men more than others, but by all means, if you're struggling with fertility, get on a supplement. It can never hurt.
Okay, that's great.
Yeah.
I love that advice.
Yeah.
Great. Well, thank you so much, Dr. Justin Houman. You are a wealth of knowledge, and I really hope that a lot of people learn from this today.
I appreciate it. Thanks for having me.
Of course. Thanks for being here.
Of course.
This was a really fascinating conversation, and you just have so much great advice to give. So it's fantastic.
Thank you.